Tell me something. I want you to imagine a farmer in northern Ghana. He's 52 years old. His father farmed the same land. His grandfather farmed the same land. For 3 generations, his family has read the sky, the soil, and the seasonal rains with the precision of scientists because their survival depended on it. For the last 8 years, the rains have stopped making sense. He cannot tell his children when to plant. He cannot plan for a harvest. The knowledge system he inherited, accumulated across generations, no longer works in the climate his children are inheriting. What is the clinical name for what this farmer is experiencing? What is the psychological framework that describes the grief of watching the environmental intelligence of your ancestors become obsolete within your own lifetime? The name is Solastalgia, and it's one of the most underdiagnosed, underfunded, and underaddressed psychological conditions in global health today. Before we begin, as usual, an important note. This episode is for educational purposes only. It's not a substitute for professional, medical, psychological, or public health advice, diagnosis, or treatment. Content draws from an introduction to global community health psychology, published by Routledge in 2026, and from peer-reviewed academic sources. Health science in this area is evolving rapidly. Always consult current guidelines and qualified professionals. If you are experiencing a health concern, physical or mental, please seek qualified professional support. Links are in the description. Let's get to it. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS, MBA, MSc, MPH, PhD. Director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria. Series 1, Foundations, Episode 4. Today, we cover Chapter 17 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Chapter 17, Climate Change and Environmental Health Psychology. Climate change is a mental health crisis. In this episode, the direct and indirect psychological pathways through which climate change produces health damage, solastalgia and eco-grief as clinically significant phenomena, the HPA axis under sustained environmental stress, why climate anxiety manifests differently in subsistence communities versus high-income communities in urban settings, Indigenous ecological knowledge as a psychological resilience resource, and the COM-B model applied to pro-environmental behavioral change. Climate change is not coming. For billions of people, it is already here, and it is already in their bodies. Let us begin. When most people think about climate change and health, they think about heat waves, floods, storms. Those are real, and they are accelerating. Direct pathways are the ones that receive the most attention. Extreme heat events produce cardiovascular stress, heat stroke, and death. Extreme weather events produce physical injuries, displacements, and acute trauma. Rising temperatures expand the geographic range of vector-borne diseases, shifting malaria, dengue, and Lyme disease into populations with no prior immunity and no established health system response. But indirect pathways are where the full psychological burden lives and where they receive far less clinical attention. Indirect pathways operate through disruptions of the social determinants of health. Climate-related food insecurity disrupts nutrition, which disrupts cognitive development in children and immune functions in adults. Climate-related displacement disrupts social networks, occupational identity, and the sense of place that anchors psychological well-being. Climate-related economic loss from failed harvests, from damaged infrastructure, from collapsed fisheries, produces financial stress that feeds directly into allostatic load. Climate change is not a future health threat. It is a present health crisis operating simultaneously across multiple biological, psychological, and social pathways, with its burden falling most heavily on populations that have contributed least to the atmospheric conditions producing it. And one of these pathways has a name that medicine has been slow to use: Solastalgia and ecogrief. Solastalgia. In 2007, Australian philosopher Glenn Albrecht introduced this term to describe a form of distress that had no name in the clinical literature, but was observed in communities experiencing environmental degradation in their home environments. Solastalgia is not homesickness. Homesickness is the distress of being away from home. Solastalgia is the distress of being at home while your home is destroyed around you. It is the grief of environmental change, of watching a landscape that anchored your identity, your memory, and your sense of safety transform into something unrecognizable. It is the evidence base that has grown substantially since 2007. Solastalgia has been documented in communities experiencing droughts, flood, wildfire, mining operations, coastal erosion, and the slow disappearance of species. The symptom profile overlaps with depression and generalized anxiety, but has a distinct quality. It is relational, it is place-based, and it's often collective. The individual is grieving alongside their community, not in isolation from it. Ecogrief is a broader category, mourning for ecological losses that extend beyond the individual's immediate environment. The extinction of species, the bleaching of coral reefs, the retreat of glaciers. Research with young people particularly shows that ecogrief is generating clinically significant distress that existing mental health frameworks are not well designed to address. The conventional therapeutic response to grief is to support the individual in adjusting to loss. But ecological grief is not a loss that can be adjusted to through individual psychological work alone, because the loss is ongoing, because it is collective, and because the appropriate response includes not just acceptance, but action. Now the biology. What sustained environmental stress does to the human body. We covered the HPA axis in episode 2. Here it reappears, but with features that are unique to environmental stress. Acute environmental disasters, floods, wildfires, cyclones produce acute HPA axis activation consistent with other forms of traumatic exposure. Post-traumatic stress disorder follows major climate events, is well documented, with rates following major flood events running between 30 and 50% in severely affected populations in the first year. But it is the chronic, low-intensity environmental stressors that produce the most insidious physiological burden. You see, research in drought-affected communities in East Africa has documented sustained cortisol elevation that persists long after the acute drought period, a biological signature of chronic uncertainty that does not resolve when rainfall returns. The farmers who cannot predict the rains, the coastal communities watching the sea rise, the pastoralists whose grazing routes are disappearing. These populations are carrying allostatic loads generated not by a single traumatic event, but by sustained environmental unpredictability. A form of chronic stress that the HPA axis was not designed to withstand indefinitely. And climate anxiety itself, which looks very different depending on where in the world you're standing. You see, climate anxiety presents very differently depending on where you live, and conflating those presentations produce interventions that miss the target entirely. In high-income urban settings in the global north, climate anxiety is often future-oriented and media-mediated. Young people in London or Melbourne are experiencing significant distress about planetary futures they can observe in news feeds and scientific reports, but which have not yet directly altered their immediate living conditions. The appropriate intervention frameworks, meaning making, values clarification, and the conversion of anxiety into purposeful action. In subsistence communities in the global south, climate anxiety is present tense and material. The farmer in Ghana I described at the opening of this episode is not anxious about the future. He is responding to current conditions that are already threatening his household's survival. The appropriate intervention framework, practical adaptation support, livelihood diversification, and community resilience building alongside psychological processing of ongoing loss. Treating these as the same clinical presentation produces responses that are useless to both populations. The same planet, vastly different experiences, completely different intervention needs. And what the communities with the longest experience of surviving environmental variability know that medicine is only beginning to study seriously. Some communities have been adapting to environmental variability for generations, not decades, generations. The knowledge systems they have developed about seasonal patterns, ecological relationship, sustainable resource use, and community coordination under environmental stress represent accumulated intelligence that mainstream climate adaptation policy consistently undervalues. Research with indigenous communities in the Arctic, in sub-Saharan Africa, and in the Pacific Islands consistently demonstrates that communities which maintain strong connections to traditional ecological knowledge show greater adaptive capacity and greater psychological resilience under climate stress. This is not romanticization, it is an empirical finding about the protective function of cultural continuity in the face of environmental disruption. When climate adaptation programming displaces traditional knowledge rather than building on it, when it treats indigenous communities as recipients of external expertise rather than as knowledge holders in their own right, it reduces the very resilience it's trying to build. And finally, while information campaigns alone cannot drive the pro-environmental behavior change like climate health demands. COMBE and pro-environmental behavior. Telling people about climate change does not change their behavior. We know this. So what does? The COMBE model: capability, opportunity, motivation, behavior provides a useful diagnostic framework. Capability means knowing what to do and having the physical resources to do it. Opportunity means knowing whether the environment makes sustainable choices accessible and affordable. Motivation, both the conscious values and the automatic habits that drive behavior. Telling communities to reduce emissions without addressing the opportunity dimension, the availability of clean alternatives, the affordability of sustainable options, the infrastructure that makes low carbon choices possible is the behavioral equivalent of telling communities to eat healthily without addressing food deserts. And telling communities to change for planetary reasons without addressing the motivation dimension, without connecting environmental behavior to values they already hold, produces short-term compliance that does not sustain. Effective climate behavior change addresses all three COMBE dimensions simultaneously. It connects environmental actions to existing values, to community protection, family welfare, cultural heritage, economic well-being, rather than asking people to adopt abstract planetary altruism as a primary motivator. Climate change is the largest public health crisis of this century. Full stop. It's also the largest unacknowledged mental health crisis because its psychological dimensions are generating disease burdens at scale while receiving a fraction of the clinical and research attention directed at its physical dimensions. Every practitioner working in health today is working in a climate-changed world. The patients experiencing heat-related cardiovascular events, the communities dealing with displacement stress, the young people processing eco-grief, the farmers carrying allostatic load generated by environmental unpredictability. They're already in your clinics, your communities, your programs. Planetary health psychology is not a future specialization. It is the present practice of every health professional who is paying attention. This episode is based on Chapter 17 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Chapter 17 is where this textbook asks the hardest question. Are health professionals prepared for the patient population that climate change is already producing? The full textbook is now available on Amazon and from routledge.com. Links in the description. Episode 5 covers Chapter 1, the foundation episode. How did this field come to exist? Why has medicine alone never been enough? If this episode has been useful to you, here's how to go deeper. Subscribe to this channel at Anaweokhai Institute on YouTube for the complete books to audio library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers. Links in the description. The practitioner's course in Global Community Health Psychology is available on Gumroad. 8 weeks. Everything this episode covers, built for best practice, link in the description. And the textbook itself, An Introduction to Global Community Health Psychology, applications at the intersection of public health and health psychology. It's available from Routledge and on Amazon.com. Everything begins there. Health is not destiny. It's been Dr. Anthony Iyore Anaweokhai. I'll see you on the next one.